retention. Secondly, this medication can reduce the ability to sweat, so don't overheat. And lastly, sit or stand up slowly to prevent that lightheadedness. So guys, just remember here, once again, you get really dry with atropine. So no pee, no see, no spit, and no poop. Now for osmotic diuretics, we have mannitol, given to decrease cerebral edema with ICP, that intracranial pressure, like with patients with head injuries and swelling in the brain with meningitis. And it's even given for increased ocular pressure for glaucoma emergencies. So the memory trick we use is mannitol. Think, man, it hurts. Or, man, ICP hurts in the head. Or basically, man, my eyes hurt for mannitol. So the ATI mentions we give mannitol for increased ICP, and we assess the level of consciousness every hour. And the HESI mentions 4 key points for mannitol. It's used to decrease ICP. For IV administration, it cannot be given PO. And one of the main side effects is edema, which begins 30 to 60 minutes after administration. Okay, you're probably thinking, hold up here. This is really interesting. Why would a diuretic, which drains fluid from the body to the potty, why would it cause edema or fluid retention? Well, the mechanism of action is it works by draining fluid out of the cell into the vascular spaces. So swollen brain cells that have all that pressure causing the ICP get drained. So all that fluid gets drained into the blood vessels, which can put the body in fluid volume overload. This leads to classic heart failure signs and symptoms like peripheral edema, fluid in the extremities, and even pulmonary edema, fluid in the lungs. So naturally, a big side effect is heart failure. So think HF for heart failure, we get HF for heavy fluid all over the body. Now, ATI mentions this when talking about mannitol. You monitor for signs and symptoms of heart failure, specifically basilarity cracks, or basically crackles inside the bases of the lungs, as well as pulmonary edema, that fluid in the lungs. Now, that's why the patho is so important here. So thanks for watching this entire video to understand all of it. Now, the next drug class is neuromuscular blocking agents. We have succinylcholine, and in this drug class, we also have 2 other drugs, pancuronium and cistacurium. But out of all of these, the big focus is on succinylcholine. It was the only drug mentioned 4 times in different quiz banks. Now, these drugs are given to paralyze the body before ET tube intubation as well as mechanical ventilation, typically for those who are difficult to intubate, like before general anesthesia or even in emergency situations. Now, the HESI mentions this is used to facilitate mechanical ventilation, and it produces deep muscle relaxation. Now, those are big terms for exams and the NCLEX. Now for the scary part. This drug only paralyzes the body, but does not sedate the patient. So patients are wide awake here. So we have a huge risk for respiratory arrest since the diaphragm, that muscle that helps us breathe, is now paralyzed. And again, it only paralyzes the body. It does not sedate the brain, so the patients can still feel pain. So talk about a horror film. It's like being trapped in your own body during surgery. You can feel everything since you have no loss of consciousness. That's why we always have to sedate with a benzodiazepine while giving this drug. So the HESI says we must give sedation, and the primary result of this drug is flaccid paralysis, not loss of consciousness. So it goes sedation first, like midazolam or benzos, ending in PAM and LAM, then acetylcholine, and then third, immediate intubation. Now for the deadly adverse effects that are always on the NCLEX and exit exams here. We have malignant hyperthermia, better known as MH. This is a life-threatening muscle abnormality from general anesthesia or acetylcholine. So the patho is really simple here. Calcium is released from the muscles when anesthetic is administered, causing muscles to contract and become rigid. This increases oxygen demand and metabolism, which results in dangerously high body temperatures. Hence the name MH, malignant hyperthermia, very hot body. So simply remember MH as the acronym MH. M for muscle rigidity and H for hot. The immediate intervention here is to notify the HCP first. Then, secondly, we administer or prepare to administer muscle relaxants like dantrolene. And then very last, we give oxygen and cooling measures. So the HESI actually asks a question about this. After administration of succinylcholine, the patient experiences a high fever and muscle rigidity. The correct answer was to prepare IV dantrolene. Now, 60% of the students got this question wrong. So again, remember, we notify the HCP first, then we also prepare dantrolene for malignant hyperthermia. And lastly, we use cooling measures. Now, our last big key point comes in the perioperative nursing care. The biggest thing and the priority here is to screen for high-risk MH. So, 3 key points to write down. Prior reaction to general anesthesia is the most critical here. We want to know if the patient has had a reaction before we give the anesthesia. Secondly, blood relatives with significant reaction to general anesthesia usually means that the patient will have a reaction. And then lastly, the alcoholics, as mentioned by the HESI, typically have a high risk for reacting in MH. Now, these are the priorities above all else for this drug. So please commit these 3 to memory, since these 3 came up multiple times on various question banks as the highest risk for that deadly malignant hyperthermia. Now for the top missed questions in the neurological section. So first question here, which nursing actions are appropriate for the nurse preparing to administer phenytoin via nasogastric or NG tube? Select all that apply. Okay, so before looking at the options, let's break this down. The question's asking the appropriate nursing actions when giving phenytoin via that NG tube. The key word there is NG tube or nasogastric tube. So before looking at the options, we're just thinking of a few things we know about the drug. So we know phenytoin is phenytoxic since it lasts a long time to prevent seizures. And the NG tube, we have to flush with water before and after we give really any drug. And specifically for this drug, you have to stop feeding tube at least 1 to 2 hours before and after giving the medication. So now for the options. Option number 1 is correct. We do hold tube feedings at least 1 hour prior to the administration of phenytoin. So the key word there is holding at least an hour before and after giving. Now option 2, flush the nasogastric tube with 30 mL of tap water before and after administration. Yes, guys, we always flush with tap water before and after. Now this one could have been tricky since some of you guys thought that sterile water is needed for an NG tube, which it's not. Tap water is perfectly fine. Now option 3 is incorrect. Monitor the blood pressure and heart rate every 15 minutes for 2 hours after the administration. So technically, no, this is not needed to monitor the heart stuff, since it's a long-term medication, so it takes a long time to kick in here. Now, option 4, monitor liver function tests on a regular basis for patients taking phenytoin. Yes, phenytoin is phenytoxic, so any toxic drug can be toxic to the liver. Now, lastly, administer phenytoin at the onset of new seizure activity. So no, this is a long-acting drug, so during seizures, we have to give a faster-acting drug, like a benzo ending in PAM and LAM, like elprazolam. Okay, next question. Which adverse effects of phenytoin should the nurse immediately report to the provider? Select all that apply. Okay, let's break this down. This question's asking for the adverse effects of phenytoin to report immediately. So this is a priority question. We're looking for the most deadly adverse effects here. So before looking at the options, think, what do you know about phenytoin, which we call phenytoxic? Well, the biggest thing is the therapeutic range. 20 is maximum. should be between 10 and 20. Second thing is the suicidal risk as well as the rash, which obviously are not good. And the earliest signs of toxicity is ataxia and slurred speech. That inability to walk and talk with that phentoxin. You can't walk it and you can't talk it. Okay, so option number 1 here. This one's correct. New reports feeling of unsteadiness when ambulating or basically walking around. Yes, the key word there is new and unsteady gait, which indicates ataxia or that difficulty walking. Option 2 is also correct. The appearance of a new rash on the patient's chest. Yes, any type of new rash, the key word is we need to report this because it could be the deadly Stevens-Johnson syndrome. Now, option 3, report feelings of hopelessness and apathetic. Yes, these are big risks for suicidal risk. And the last 2 options are also correct here. A morning phentotoin level of 26 is technically toxic. Remember, the range is between 10 and maximum of 20. And lastly, difficulty forming words or sentences. Yes, phentoxic means talking. So, having difficulty forming words or sentences, or even slurred speech, this is an early sign of toxicity. Now the next question here, the healthcare provider has prescribed 4 milligrams of succinylcholine to be administered IV push during a rapid sequence intubation. Which is the nurse's priority action when preparing to administer this medication? All right, that was a big question, so let's break this down. The question's asking for priority action when giving succinylcholine. So, since this question's asking for priority action, we always have to think, what kills the patient first? So before looking at the options, we're just thinking loss of life as well as loss of limb. So we know that succinylcholine, what kills the fastest is malignant hyperthermia. So we have to screen for those 3 criteria. A prior reaction to general anesthesia, blood relatives with significant reaction to that general anesthesia, as well as alcoholics, as mentioned by the HESI. So option number 1 is incorrect. Check the patient's core body temperature. Guys, that's not the main priority here. Now option 2 is correct. Ask the patient about a history of alcohol abuse. Yes, we always screen for alcoholism. The key is to anticipate the deadly malignant hyperthermia. Now option 3 was a little bit tricky. Prepare a dose of midazolam as prescribed for sedation. Now this one's really close as a distractor. So yes, we do give benzos for sedation, but it does not come before screening for those deadly adverse effects. And option number 4, also incorrect. Ensuring a non-rebreather mask is at the bedside prior to administration. So oxygen is not the biggest priority here when we're faced with deadly adverse effects. Now the last question here, which instructions should the nurse include in the plan of care for a patient newly prescribed carbidopa and levodopa for the treatment of Parkinson's disease? Select all that apply. Okay, let's break this down. The question's asking for the plan of care for the key term newly prescribed carbidopa and levodopa. So before looking at the options, we're thinking a few things that we know about this drug. So number 1, levodopa, we have to leave the protein since it decreases the absorption of this drug. And 2, levodopa leaves more dopamine inside the brain. So the side note is any drug that acts on the neurotransmitters, the dopamine inside the brain, typically affects balance and typically takes a long time to kick in. So now let's look at the options here. Option number 1, if you don't notice improvements in your symptoms within 1 week, notify the provider. This is big time incorrect. Any drug that acts on the brain usually takes a few weeks. So specifically, levodopa takes about 2 to 6 weeks to kick in. Typically, any neurotransmitter, guys, so put that in your back pocket for the antidepressant section. Now, option 2, when going from sitting to standing position, be sure to change your position slowly. Yes, again, typically any brain drugs affecting balance, we have to do slow position changes. And option 3, It's a good idea to remove any clutter from your home that could cause you to trip and fall. Well, of course, so yes, it's correct. Preventing falls with Parkinson's, that unsteady gait, and those shuffling feet. And option number 4, call your provider if you notice your urine change to a slightly reddish color. This one was pretty tricky, but no, it's incorrect. Colored urine is normal. And lastly, option number 5, we avoid eating meals that contain large amounts of protein while taking this medication. Yes, this is correct. Levodopa, you leave those high protein meals. All right, guys, that wraps it up for this segment. Don't forget to take your